How does the prospective payment model fix these flaws, and how is it different than what's been tried before?
Well, what's been tried before, let's go through a couple of things and say, let's go back to the 90s where people were using words like capitation that scared people. The difference between now and then is dramatic. Number one is the technology we have today is drastically different than we had, 30 years ago, for sure. We can all recognize that. So therefore there's data and information that we can have on both sides of a transaction that wasn't there before to learn. And there's involvement with the patient with technology that you never had before. You also now have exploding healthcare costs, and so there's a heightened sense from all purchasers, whether it be the government or employers or patients, about the cost of care. So there's more attention to this now. Inside a subgroup of America right now called Medicare Advantage, we're already seeing this payment model happen, and we have for the last 5 or 10 years. And you've seen a fairly high growth of the Medicare Advantage product across America. The reason it's growing, in my opinion, one of the reasons is it does align the incentives with a prospective payment model to the primary care physician to align the right outcomes to be incentivized for. And so it is actually, when you say what's different about it, it's different from the 90s for sure, in the technology ways I mentioned, as well as the attention of the cost. But we actually have a little bit that's happening right now. And so how it solves it was the first part of that question, is how does prospective payment solve it? It's not necessarily a silver bullet, but man, it gets you on the right field of play for sure. We're not even on the right field of play. Attaching a care delivery model with an appropriate financing model is the key. Right now, those are disjointed. This brings them together. And it does so for primary care because of the reasons I mentioned. Primary care is a relational, longitudinal based care model that we actually then, in a prospective payment model, would organize care, not episodically in a 10 by 10 exam room. You then become more team-based in how you do things. Right now, there's nothing in fee-for-service that pays for team-based care, and nothing that in fee-for-service really that pays traditionally for coordination of care. And we all know that teams perform better than individuals. And so why wouldn't we have a payment model that encourages team-based care and encourages longitudinal care and encourages you to take care of those people on the front end rather than proactively, rather than reactively? And why wouldn't we do it in any care setting that makes sense, including the home? We have all this technology today. So all of a sudden, in a prospective payment model, it unlocks so much of the rigor and of today's model that doesn't get the outcomes we want. It unlocks technology opportunities. It unlocks mode of delivery and receiving from the patient from all the different technologies. It affords the incentive on the patient to go ahead and engage more with the physician and their team. It affords the physician, the team, the incentive to engage more proactively with the patient because you actually have a payment model that's paying you for ongoing care. So it really does bring together the care delivery model and the financing model to a more congruent state to deliver the outcomes. Now, you still have to build in the right incentives and the right outcomes that you're measuring for sure, but at least now you're on the right playing field. And COVID has shown that what a destruction that incongruence can be, because all of a sudden when we're told across the country to stay at home and shelter at home, which is the right thing to do for our health, and the only way that physicians can get paid most of the time is in the 10 by 10 exam room, and that's no longer available. You've absolutely crushed the primary care layer of healthcare in America. I mean, absolutely decimated it. That happens to be the layer that's needed at all times, but especially in the COVID moment, to help people with all their extra issues around coordinating care, getting medications, making sure their chronic diseases are being managed, their mental health issues are skyrocketing, not to mention the acute issues of potentially having COVID and managing that. We need our primary care layer more than ever. Yet the incongruence of the payment model and the delivery model absolutely decimated it in this moment.